The following episode is brought to you by the American Urological Association. This special episode comes to you from the AUA Update Series, Volume 45, Lesson 15, Case-Based Testicular Cancer Clinical Practice Guidelines. Now in its 45th installment, the AUA Update Series is renowned for delivering high-quality lessons to practicing urologists, fellows, and residents. All content is developed by internationally recognized experts in urology, making the AUA Update Series the most professional and sought-after self-study program available. Improve your practice and patient care by staying abreast of the latest treatments and surgical techniques in urology. For more information or to subscribe to the AUA Update Series, please visit the AUA University.
AUA Update Series, Volume 45, Lesson 15, Case-Based Testicular Cancer Clinical Practice Guidelines. Authors: Konstantinos E. Morris, M.D., B.S., Khalid Y. Al-Khatib, M.D., MMSc, Philip M. Pierorazio, M.D., and Timothy A. Masterson, M.D., FACS. Testicular cancer, while overall uncommon, is among the most common tumors in young men, aged 20 to 40 years. The majority of these tumors are germ cell in origin. Overall incidence has been rising and finds itself at 6.4 per 100,000, American Cancer Society, with approximately 460 deaths annually among U.S. men. Testicular cancers can be split into two categories, germ cell and non-germ cell, including the sex cord stromal tumors and Leydig or Sertoli cell tumors. Germ cell tumors are further broken down as seminomatous or non-seminomatous germ cell tumors. Non-seminomatous germ cell tumors include any elements of embryonal carcinoma, yolk sac, choriocarcinoma, and teratoma. Within the category of seminoma, there are classic seminoma and spermatocytic tumor, the latter of which was previously known as spermatocytic seminoma and is categorized as a non-germ cell neoplasia in situ. Risk factors for testicular neoplasms are cryptorchidism, intratubular germ cell neoplasia, as well as family or personal history. The only sign or symptom is often a painless testicular mass. Scrotal ultrasound is a common first step after scrotal examination and is often followed by tumor marker assessment. These include alpha-fetoprotein, beta-human chorionic gonadotropin, and lactate dehydrogenase. Individual markers have different half-lives and are elevated with different tumor histologies. Alpha-fetoprotein, with a half-life of 5 to 7 days, can be elevated in yolk sac and embryonal carcinoma, but does not elevate with seminoma or choriocarcinoma. Human chorionic gonadotropin and its 24 to 48-hour half-life may be elevated in embryonal carcinoma, choriocarcinoma, and seminomas. With elevation in alpha-fetoprotein and/or human chorionic gonadotropin, falsely positive results may occur due to liver or biliary abnormalities, as well as marijuana use. Lactate dehydrogenase, with a half-life of about 24 hours, is a rather nonspecific marker, but may be used as a surrogate for disease burden in more advanced cases and helpful in International Germ Cell Consensus Classification risk stratification. Of note, microRNA is a new and evolving area of research with hopes that it may help in those with inconclusive testicular masses and in surveillance. Included in the following are a series of clinical case vignettes that highlight several principles of management across the various categories of early-stage germ cell tumor. These emphasize various aspects of guideline recommendations. Case 1. The patient is a 34-year-old healthy man who presents to the clinic complaining of a painless lump near his right testicle. What is the differential diagnosis for this young male with a painless testicular mass? Would this differential change if the patient were 68 years old? AUA Guidelines Statement 1. A solid mass in the testis, identified by physical examination or imaging, should be managed as a malignant neoplasm until proven otherwise. The most common presentation of testicular cancer is a painless, enlarging scrotal mass. Pain, especially acutely, is less common, but when present is secondary to infarction or intratumor hemorrhage. A painless mass should be presumed to be malignant until proven otherwise, and imaging as well as serum tumor markers should be obtained. For this patient, tumor markers are within normal limits. Testis imaging. The imaging should be obtained promptly as to not delay diagnosis. AUA Guidelines Statement 4. Scrotal ultrasound with Doppler should be obtained in patients with a unilateral or bilateral scrotal mass suspicious for neoplasm. Ultrasound is the preferred method as it is non-invasive, cost-effective, available, and performs well in determining malignant versus benign processes. Of note, in cases of advanced germ cell tumor, there may be spontaneous regression of the primary tumor with only scar and intratubular calcifications remaining. AUA Guidelines Statement 4. MRI should not be used in the initial evaluation and diagnosis of a testicular lesion suspicious for neoplasm. MRI may be used as a secondary test to differentiate between solid mass and vascular abnormality, but should never delay orchiectomy. For our patient, there was no solid mass identified on the ultrasound, but rather an epididymal cyst. Bilateral testicular microlithiasis was also identified. Had the imaging been inconclusive, what follow-up would be necessary? AUA Guidelines Statement 6. Patients with normal serum tumor markers, human chorionic gonadotropin and alpha-fetoprotein, and indeterminate findings on physical examination or testicular ultrasound for testicular neoplasm should undergo repeat imaging in 6 to 8 weeks. Testicular microlithiasis. How do we define testicular microlithiasis? Are they considered precursors to testicular cancer? Testicular microlithiasis is innumerable, more than 5 foci per testis, small echoes scattered throughout the testis. AUA Guidelines Statement 6. Testicular microlithiasis in the absence of solid mass and risk factors for developing a germ cell tumor does not confer an increased risk of malignant neoplasm and does not require further evaluation. Routine self-examination remains the standard screening for all men, and additional screening measures or imaging are not currently recommended for the presence of microlithiasis. For this patient, found to have an epididymal cyst with scattered microlithiasis and normal serum tumor markers, he will continue with routine self-examinations. No further imaging or lab testing is required. Case 2. A 29-year-old male presents with a right-sided testicular mass, and subsequent ultrasound confirms a heterogeneous 1.7 centimeter mass concerning for non-seminomatous germ cell tumor. He has preoperative alpha-fetoprotein of 250 nanograms per milliliter, human chorionic gonadotropin of 19 nanograms per milliliter, and lactate dehydrogenase of 5 units per liter. He is counseled on the preoperative risks of hypogonadism and infertility. He subsequently undergoes radical orchiectomy via an inguinal approach with high ligation. A testicular prosthesis was offered, but he declined. Pathology returns mixed non-seminomatous germ cell tumor with components of 75% embryonal carcinoma and 25% seminoma. The tumor was limited to the testis without lymphovascular invasion, PT1A. Imaging and markers. At this point, what imaging, if any, should this patient undergo? AUA Guidelines Statement 18. In patients with newly diagnosed germ cell tumor, clinicians should obtain cross-sectional imaging of the abdomen and pelvis with IV contrast, or MRI if CT is contraindicated. AUA Guideline Statement 19A D. In patients with newly diagnosed germ cell tumor, clinicians must obtain chest imaging, and clinicians may preferentially obtain a CT scan of the chest over a chest X-ray, and should prioritize CT chest for those patients recommended to receive adjuvant therapy. The retroperitoneum is the primary landing site for most testicular cancers. Contrast CT is the imaging of choice and has been found to be highly specific for imaging of nodal disease. Outside of the retroperitoneum, the lungs are the second most common site of metastasis, and metastases that bypass the retroperitoneum are almost only seen with non-seminomatous germ cell tumor as compared to seminoma. It has been shown that CT chest is more accurate than chest X-ray for the detection of intrathoracic metastases. However, both overstaging with CT and understaging with X-ray remain limitations. CT, chest, abdomen, and pelvis does not show any retroperitoneal or extraretroperitoneal disease. At what interval should serum tumor markers be repeated? If elevated, when should adjuvant treatment or surgery decisions be made? AUA Guideline Statement 14. Nadir's serum tumor markers, alpha-fetoprotein, human chorionic gonadotropin, and plus or minus lactate dehydrogenase should be repeated at appropriate half-life time intervals after orchiectomy for staging and risk stratification. AUA Guideline Statement 15. For patients with elevated alpha-fetoprotein or human chorionic gonadotropin post-orchiectomy, clinicians should monitor serum tumor markers to establish nadir levels before treatment only if marker nadir levels would influence treatment. Serum tumor markers will fall according to their expected half-lives. Serial assessment of markers can be obtained to trend their course over the 5 to 6 half-lives expected to achieve normalization to avoid overtreatment or misdiagnosis. Any persistent rise in alpha-fetoprotein or human chorionic gonadotropin in a patient post-orchiectomy raises concern for extratesticular disease. AUA Guideline Statement 22. Management decisions should be based on imaging obtained within the preceding 4 weeks and serum tumor markers, human chorionic gonadotropin and alpha-fetoprotein, within the preceding 10 days. Non-seminomatous germ cell tumor may be fast-growing, and treatment decisions must be made based on accurate information to decrease morbidity and avoid undertreatment. If imaging results would have been equivocal, what treatment decision should be made? AUA Guideline Statement 25. In patients with normal serum tumor markers, human chorionic gonadotropin and alpha-fetoprotein, and equivocal imaging findings for metastasis, clinicians may consider repeat imaging in 6 to 8 weeks to clarify the extent of disease prior to making a treatment recommendation. Borderline nodes should be reimaged. If enlarging, this would favor metastatic disease, while a decrease in size could point toward a benign process. Staging. The 29-year-old male of interest has repeat tumor markers drawn at the recommended 5 to 6 half-lives following surgery. His alpha-fetoprotein, human chorionic gonadotropin, and lactate dehydrogenase are all within normal limits. At this point, AUA Guideline Statement 21, patients should be assigned a TNMS category to guide management decisions. What is this patient's TNMS classification? What is the stage grouping of his disease? This patient with normal serum tumor markers, tissue diagnosis of non-seminomatous germ cell tumor limited to the testis without lymphovascular invasion, no evidence of regional lymph node metastasis, and no sign of distant metastasis, has PT1N0M0S0 disease. This places him in the stage 1A category. Of note, the American Joint Committee on Cancer's staging system utilized is based on post-orchiectomy tumor markers to properly stage. Treatment versus surveillance. For this patient with stage 1A non-seminomatous germ cell tumor, what are his options for next steps? How would 1B grouping change your recommendation? AUA Guidelines Statement 29. Clinicians should recommend surveillance for patients with stage 1A non-seminomatous germ cell tumor. Retroperitoneal lymph node dissection or one cycle of bleomycin, etoposide, and cisplatin chemotherapy are effective and appropriate alternative treatment options for patients who decline surveillance or are at risk for noncompliance. AUA Guidelines Statement 30. For patients with stage 1B non-seminomatous germ cell tumor, clinicians should recommend surveillance, retroperitoneal lymph node dissection, or 1 or 2 cycles of bleomycin, etoposide, and cisplatin chemotherapy based on shared decision-making. Relapse for patients with 1A non-seminomatous germ cell tumor on surveillance protocol is low, about 15%, and long-term disease-specific survival approaches 100%. For men with 1B non-seminomatous germ cell tumor, the presence of lymphovascular invasion confers relapse rates of 40% to 50% and remains the highest predictor of disease progression. Another risk factor, which does not necessarily place the patient within the 1B category, would be a majority embryonal carcinoma pathology of the orchiectomy specimen, conferring greater than 40% risk of relapse. For those patients with a greater risk of relapse, adjuvant therapy with platinum-based chemotherapy or retroperitoneal lymph node dissection can be considered. Fortunately, just one round of bleomycin, etoposide, and cisplatin can take the recurrence rate below 2% with few complications. If primary pathology had shown 65% embryonal carcinoma, 20% seminoma, and 15% embryonic-type neuroectodermal tumor, would this change your recommendation above? AUA Guideline Statement 31. Patients with stage 1 non-seminomatous germ cell tumor and any secondary somatic malignancy, also known as teratoma with malignant transformation, in the primary tumor at orchiectomy, should undergo retroperitoneal lymph node dissection. Teratoma is unique in its ability to transform into a somatic malignancy, such as embryonic-type neuroectodermal tumor, sarcoma, or carcinoma. These have shown little response to histology-directed chemotherapy, especially when compared to their germ cell tumor counterparts. Given the insensitivity of these tumors to chemotherapy and worse stage-for-stage survival when compared to germ cell tumor without somatic transformation, retroperitoneal lymph node dissection is indicated to minimize the risk of disease progression that is associated with few salvage options. For these patients, indicators of increased overall survival are non-primitive neuroectodermal tumor histology, gonadal primary, and fewer chemotherapy regimens. Long-term follow-up. For this patient, following a surveillance protocol, how often should tumor markers, examination, and imaging be repeated? For what duration should surveillance be carried out? AUA Guidelines Statement 39. In patients with stage 1 non-seminomatous germ cell tumor undergoing surveillance after orchiectomy, clinicians should perform a physical examination and obtain serum tumor markers, alpha-fetoprotein, human chorionic gonadotropin, and plus or minus lactate dehydrogenase every 2 to 3 months in year 1, every 2 to 4 months in year 2, every 4 to 6 months in year 3, and every 6 to 12 months for years 4 and 5. AUA Guideline Statement 40. In patients with stage 1 non-seminomatous germ cell tumor undergoing surveillance after orchiectomy, radiologic assessment, chest X-ray, and imaging of the abdomen with or without the pelvis should be obtained every 3 to 6 months in year 1, starting at 3 months, every 4 to 12 months in year 2, once in year 3, and once in year 4 or 5. For stage 1 non-seminomatous germ cell tumor, many relapses will occur in the first year, and as such, surveillance following orchiectomy is most intense at this time. With higher relapse rates among those with lymphovascular invasion, follow-up at the short end of the specified range is recommended. Overall, for those with lymphovascular invasion, 95% of recurrences occur in the first 2 years, while lymphovascular invasion negative patients have 89% of recurrences within the first 2 years. In terms of imaging, CT of the abdomen and pelvis is the most common modality for detection of relapse overall, at about 52%, with the retroperitoneum, 66%, being the most common site. Among these patients with concerning imaging, only roughly 50% have elevated serum tumor markers. Chest imaging and physical examination, to a much lesser extent, 3%, have been responsible for detecting relapse. Case 3. A 35-year-old male underwent a left radical inguinal orchiectomy for a solid mass in his left testicle. Histopathology showed a PT1, 2.5 centimeters of 100% seminoma, no rete testis invasion, and no lymphovascular invasion. His pre- and postoperative serum tumor markers are normal. His post-orchiectomy CT scans showed a solitary para-aortic adenopathy of 2.6 by 2.3 centimeters, and his tumor markers remain normal. What are the treatment options for men with stage 2B seminoma? AUA Guideline Statement 27A. For patients with stage 2A or 2B seminoma with a lymph node less than or equal to 3 centimeters, clinicians should recommend radiation therapy or multi-agent cisplatin-based chemotherapy based on shared decision-making. Moderate recommendation, evidence level grade B. AUA Guideline Statement 27B. For patients with stage 2A or 2B seminoma with a lymph node less than or equal to 3 centimeters who wish to avoid the long-term toxicities associated with chemotherapy or radiation therapy, retroperitoneal lymph node dissection may be offered as an appropriate and effective treatment option. Moderate recommendation, evidence level grade B. AUA Guideline Statement 27C. For patients with 2B seminoma with a lymph node greater than 3 centimeters, chemotherapy is recommended. Moderate recommendation, evidence level grade B. Stage 2 seminoma is associated with an excellent prognosis and disease-specific survival that approaches 100%. For decades, the mainstay of treatment for stage 2B disease, especially those with bulky lymphadenopathy, greater than 3 centimeters, was cisplatin-based chemotherapy. AUA, National Comprehensive Cancer Network, and European Association of Urology guidelines recommend 4 courses of etoposide and cisplatin, or 3 cycles of bleomycin, etoposide, and cisplatin. Chemotherapy and radiation are associated with a significant long-term treatment-related morbidity, including the risk of secondary cancers and cardiovascular disease. Primary retroperitoneal lymph node dissection for select patients with stage 2 seminoma and normal serum tumor markers is an option based on recent data from Phase 2 clinical trials. Primary retroperitoneal lymph node dissection for stage 2 seminoma is based on the predictable lymphatic drainage of seminoma through the retroperitoneum and significant data supporting the oncologic efficacy of retroperitoneal control with external beam radiotherapy for decades. Given similar concerns for long-term toxicities, such as secondary malignancy and cardiovascular toxicity, radiotherapy has lost favors in many centers for younger men with stage 2 seminoma. Evidence supporting primary retroperitoneal lymph node dissection for stage 2 seminoma stem from published phase 2 clinical trials and retrospective studies, including Prime Test trial, SEMS trial, Cotrams trial, Matulowicz et al. Study, Swinateka study, and Tachibana et al. Study. A critical observation from these trials is the PNO rate, representing the proportion of patients with no pathological nodal involvement after retroperitoneal lymph node dissection. This ranged between 3% and 22%, suggesting that some patients may have been overtreated had they received upfront chemotherapy or radiotherapy instead of surgery. Despite variability in patient selection, overall survival remained near 100% across all studies, reinforcing the oncologic safety of retroperitoneal lymph node dissection. Notably, most recurrences occurred outside the retroperitoneal lymph node dissection field, indicating that distant metastases, not surgical inadequacy, were the primary cause of relapse. From a safety standpoint, retroperitoneal lymph node dissection demonstrated a low overall complication rate, particularly when performed at high-volume centers. Across these studies, Clavien-Dindo 3 complications ranged from 2% to 12%, with no grade 4 or 5 complications reported. Given these findings, retroperitoneal lymph node dissection emerges as a viable alternative to systemic therapy, particularly for carefully selected patients. Optimal outcomes depend on accurate staging, patient selection, and treatment at high-volume centers with surgical expertise. Further research should focus on biomarker-driven risk stratification, for example, microRNA 371, to refine patient selection and minimize over-treatment. Case 4. A 42-year-old man presents with bilateral, palpable testicular masses that are suspicious for germ cell tumor. His tumor markers are overall normal, alpha-fetoprotein 11, borderline high, and beta-human chorionic gonadotropin undetectable. The ultrasound demonstrates a 2-centimeter right testicular mass, hypoechoic and vascular, with microlithiasis present, and a 1.5-centimeter left testicular mass, hypoechoic and vascular. He has no significant medical history, no trauma, and no undescended testicles or hernia repairs. He is in a supportive homosexual marriage, and they are not interested in paternity. Both masses are palpable on physical examination. The left is more prominent than the right. What is the role of testis-sparing surgery in the management of germ cell tumors? AUA Guideline Statement 8. Patients with a testicular lesion suspicious for malignant neoplasm and a normal contralateral testis should undergo a radical inguinal orchiectomy. Testis-sparing surgery is not recommended. Transscrotal orchiectomy is discouraged. Strong recommendation, evidence level grade B. In a select group of people, radical orchiectomy testis-sparing surgery may be considered. AUA Guideline Statement 11A. Testis-sparing surgery through an inguinal incision may be offered as an alternative to radical inguinal orchiectomy in highly selected patients wishing to preserve gonadal function with masses less than 2 centimeters and 1. Equivocal ultrasound or physical examination findings and negative tumor markers, human chorionic gonadotropin and alpha-fetoprotein. 2. Congenital, acquired, or functionally solitary testis. Or 3. Bilateral synchronous tumors. Conditional recommendation, evidence level grade C. While testis-sparing surgery may be considered in select patients, additional counseling should be undertaken. AUA Guidelines Statement 11B. Patients considering testis-sparing surgery should be counseled regarding 1. Higher risk of local recurrence, 2. need for monitoring with physical examination and ultrasound. 3. Role of adjuvant radiotherapy to the testicle to reduce local recurrence. 4. Impact of radiotherapy on sperm and testosterone production. And 5. The risk of testicular atrophy and need for testosterone replacement therapy and/or subfertility or infertility. Moderate recommendation, evidence level grade C. In this patient with bilateral palpable testicular masses, the concern is for bilateral germ cell tumor. Approximately 2% of men with testicular cancer will present with or develop bilateral disease. Testis-sparing surgery can be offered as a means to diagnose and treat testicular masses when there is concern for a benign lesion or when surgery may render a patient anatomically or functionally anorchic. Statement 11b. Therefore, testis-sparing surgery should be considered for diagnostic purposes when there is a high suspicion of benign etiology or there is concern for future fertility or hormonal production in men at risk for becoming anorchic. Support from an experienced pathologist is critical. AUA Guidelines Statement 11C. When testis-sparing surgery is performed, in addition to the suspicious mass, multiple biopsies of the ipsilateral testicle normal parenchyma should be obtained for evaluation by an experienced genitourinary pathologist. Moderate recommendation, evidence level grade C. Benign histology may be encountered in up to 80% of testicular lesions smaller than 2 centimeters with a long duration of symptoms, greater than 6 months. The possibilities should be reviewed comprehensively with the patient before surgery, as the plan for preservation of the testicle, if frozen, reveals a benign, malignant, or indeterminate finding. Testis-sparing surgery should be performed cautiously in men with a known diagnosis of germ cell tumor. First, testis-sparing surgery is seldom feasible for larger tumors, greater than 3 centimeters, because a complete excision frequently leaves insufficient residual testicular parenchyma for preservation. Germ cell neoplasia in situ is almost universally present in the residual testicle for men with germ cell tumor. For patients with germ cell neoplasia in situ, adjuvant radiotherapy to the residual testis is usually sufficient to prevent the development of a germ cell tumor and may preserve Leydig cell function and thereby testicular androgen production, but will lead to permanent sterility in the treated testis. Leydig cell function may still decline over time. Adjuvant radiotherapy may be delayed after testis-sparing surgery if fathering a child is desired. Should this patient undergo testis-sparing surgery? Based on imaging and physical examination, this patient has bilateral, palpable testicular masses that are highly indicative of bilateral, synchronous testicular cancer without metastasis. During preoperative counseling, the patient indicated that he was not interested in paternity. The left was deemed to be more concerning than the right, so the decision was made to proceed with potential testis-sparing surgery on the side most likely to be salvaged. This patient underwent a right testis-sparing surgery. Frozen section analysis revealed germ cell tumor, likely seminoma, and he underwent a reflex right radical inguinal orchiectomy with placement of a testicular prosthesis. 2 weeks later, after initiation of exogenous testosterone replacement, he underwent a left radical inguinal orchiectomy with testicular prosthesis placement to prevent the abrupt transition to being both anorchic and hypogonadal in a single setting. Case 5. A healthy 72-year-old man presents after having multiple attempts at a right inguinal hernia repair. Scrotal ultrasound revealed a 1.2 centimeter hypoechoic right testicular mass and a bothersome, moderate-sized hydrocele. He proceeded to hydrocelectomy, which ultimately resulted in a scrotal orchiectomy. Final pathology revealed a small 1.0 centimeter organ-confined seminoma without lymphovascular invasion or rete testis invasion. What is the management of patients undergoing scrotal orchiectomy for germ cell tumor? AUA Guidelines Statement 8. Patients with a testicular lesion suspicious for malignant neoplasm and a normal contralateral testis should undergo a radical inguinal orchiectomy. Testis-sparing surgery is not recommended. Transscrotal orchiectomy is discouraged. Strong recommendation, evidence level grade B. The first step in management should really be prevention. If there is any consideration of testicular mass or germ cell tumor, an inguinal approach with high ligation of the spermatic cord is the preferred surgical approach. Scrotal orchiectomy is discouraged by the guidelines and data sources. Metadata indicate that up to 20% of men in the historical series experience scrotal violation for either transscrotal orchiectomy, scrotal exploration, or testicular mass biopsy or aspiration. Local recurrence rates were only 2.5% in the men with scrotal violation, 0% in men undergoing radical inguinal orchiectomy. There were no differences in rates of metastatic disease or all-cause mortality in those undergoing a transscrotal approach. However, a significant proportion of men with scrotal violation either underwent excision of the scrotal skin scar, adjuvant radiotherapy, and/or routine chemotherapy per standard of care. How would you consult the patient? What risk factors should he be aware of? AUA Guideline Statement 10. Patients who have undergone scrotal orchiectomy for malignant neoplasm should be counseled regarding the increased risk of local recurrence and may rarely be considered for adjunctive therapy, excision of scrotal scar, or radiotherapy for local control. Moderate recommendation, evidence level grade C. Scrotal violation, which occurs when the integrity of the scrotal wall or tunica vaginalis is disrupted during surgical management of testicular cancer, may result from transscrotal orchiectomy, scrotal exploration, testicular biopsy, or incidental injury during unrelated procedures. Outcomes associated with scrotal violation show that while it significantly increases the risk of local recurrence, 2.5%, compared to standard inguinal orchiectomy, 0.0%, it does not appear to affect metastasis, 16.6% versus 18.1%, or overall survival, 10.2% versus 8.0%. The presence of residual tumor in 9.3% of patients undergoing scrotal scar excision further suggests that microscopic tumor seeding may occur. To mitigate the risks associated with scrotal violation, several management strategies have been recommended, including scrotal scar excision, or for those with seminoma, they typically receive adjuvant radiotherapy to the scrotal region. In some cases, close monitoring with imaging and tumor markers is an alternative for patients without evidence of tumor spread. Ultimately, the gold standard remains radical inguinal orchiectomy, as it minimizes the risk of tumor spillage and eliminates the need for additional interventions. How should this patient be managed? Given the low volume of germ cell tumor, the organ-confined nature of the seminoma without risk factors, and the history of multiple prior inguinal surgeries, the decision was made for close surveillance of the scrotum along with standard surveillance for stage 1 seminoma. The patient completed full radiographic staging for early-stage seminoma. He elected surveillance with serial scrotal examinations. In patients with more advanced local tumors, consideration of wide excision of the scrotal skin and cord remnant should be considered. Radiotherapy can also be considered. In men undergoing systemic chemotherapy, there is minimal risk of local recurrence, and neither surgery nor radiotherapy should be recommended. Did you know? A solid testicular mass is malignant until proven otherwise. Prompt imaging and tumor markers are essential. Testicular microlithiasis does not increase cancer risk and requires no additional screening. Stage 1 non-seminomatous germ cell tumor with lymphovascular invasion or embryonal carcinoma has a higher recurrence risk and may need adjuvant therapy. Testis-sparing surgery is an option for small, less than 2 centimeter tumors, solitary testis, or bilateral disease. Scrotal orchiectomy increases local recurrence risk. Scrotal scar excision or radiotherapy may be needed. For more information or to claim CME, please visit the AUA University at auanet.org/university.